Good afternoon, everyone, and welcome to the last session of the day. I hope that it's been enjoyable. We've certainly enjoyed it here. As Mark mentioned, I do have a PharmD degree, but I've only been graduated for about 10 years. I might look older than a 10-year graduate, and that's because I did do an undergrad degree as well, and I actually managed a pharmacy for 16 years before I went back and got my Doctor of Pharmacy degree. So why I tell you this is just to let you know that I do understand community pharmacy. I actually still sit on the board of a group of independent pharmacies. And I'm also the consultant of primary care for the Ontario Pharmacists Association. So that perspective as well about where primary care wants to go and where we should be going as health professionals and what we should be doing as pharmacists as part of that big picture. And where we are going and where we should be going is in a healthy approach, preventative management, disease management, and risk assessment. So we can help you with that. We've used the word innovative a lot over the weekend, and our title here is Innovative Approaches to Disease Management Clinics. Disease management clinics are really a win-win-win opportunity. They're innovative, they're interactive. Patients can get involved with these different clinics with the different devices available, and we can help them better understand their health and better understand their risks and create that disease state awareness that's so important. As the most accessible healthcare professional and as the healthcare professional that sees more patients than anybody else, we certainly have an opportunity to identify those patients that otherwise might fall through the cracks and help them understand their health better and get them into the healthcare system where appropriate. Osteoporosis is an excellent example in terms of a silent disease where people aren't going to bother their doctors about something that may never happen. But we have the ability now to look at the risks that the patient has and move them on through the system if need be. So there's a lot of positives here in terms of building loyalty and trust with our patients that we have at the moment, but also in the greater community to create awareness around health risks, etc., and to hopefully bring people, other people in that are potential clients. PromoAd has a number of clinics available, and there are forms at the back that you can sign in terms of fax back forms with the clinics listed. Today we're going to focus on 3 particular clinics and using the devices as appropriate. So the first is the osteoporosis risk assessment using the OmniSense ultrasound bone sonometer. The second we'll talk about is the skin damage clinic using the twin image UV detect camera. And the third is the body fat, water weight, and total body weight assessment with the TBF 300 body composition analyzer. So using these in and of themselves, these devices, is no good if we don't put perspective around the health risks for the patients. So PromoAd does provide education, disease management education, patient counseling skills education, and patient counseling approaches, and all the tools that are needed to help inform that patient about their particular health risks. The devices are available on a rental basis. Training is available, and we're even inviting you to come to North York, to the corner of Dufferin and Steeles in that area for a personal introduction to any of the devices that we have available that you might be interested in. Today is more of an overview, just so you know what is available and how these clinics work. In terms of promotion, of course, that's extremely important as well. If we have these great clinics but nobody knows about them, obviously they're not going to do anybody any good. So we can help you with that promotion as well in your community at large. So let's start with a discussion of the osteoporosis risk assessment clinic. What we want to do here is obviously help patients better understand their risk for osteoporosis. And we're going to base that assessment on the results of the ultrasound bone sonometer, but also on the major and minor risk factors that are listed in the Canadian Osteoporosis Guidelines. So they complement each other really. The Canadian Osteoporosis Guidelines list major risk factors, minor risk factors, and what they say is that if somebody has one major risk factor or two minor risk factors, they should move on to get the dual X-ray absorptiometry test done, DXA as we usually know it as. That's the gold standard for osteoporosis risk assessment. And that's the gold standard for diagnosis. But what we're doing here is assessment. I want to make that clear. We are not diagnosing. We're not going to tell a person they have osteoporosis. We're not going to tell a person they have osteopenia. We're going to move people on for further assessment to their physician if we think it's warranted via either the results and or their listing of major or minor risk factors according to the Canadian Osteoporosis Guidelines. So what I'd like to do is ask Antonella and Mark to come up. They're going to start demonstrating the omnisense for us while I continue to speak about risk assessment and osteoporosis definition. Osteoporosis defined as a skeletal disorder characterized by compromised bone strength, predisposing a person to an increased risk of fracture. I think we're pretty much in tune with that. But what I want you to remember is that it's also a reflection of bone quality. So it's not just the density of the bone, it's how it's structured. It's like a building. If you have building with parallel planks, it could just collapse. But if you have a building that is structured appropriately, it's going to be stronger. So that's the same with bone. And what we're really doing here with the sonometer is looking at bone quality. What Mark's doing now is measuring Antonella's the length of her arm from the tip of her elbow right up to the tip of her third finger. Why he's doing that is we're going to be measuring the speed of sound through the distal radius bone, which goes from the bottom of the of your thumb area right up to your elbow. And so what he did, he measured halfway the distance between the tip of the elbow and the finger, and he put a line, and now he's getting way ahead of me, and he's putting gel on the probe and on the arm, and he's getting ready to do the test. So the reason we do the test at the halfway point there is because that is where the studies have been done to test this particular machine, and that's where the distal radius bone lies. So I'm going to continue to talk. We're going to hear some beeping in a moment, and that will be Mark using the probe that he's got in his hand, and it's going to be the sound of the ultrasound actually meeting the bone. So that's what I'm talking about. While he does that, because it takes a couple of minutes, and it takes him a lot less time likely than it's going to take you the first couple of times, because there is a technique involved. But why do we assess osteoporosis risk? Well, it's the Rodney Dangerfield of diseases. It just doesn't get the respect it's deserved. It's the most common metabolic disease. 25% of postmenopausal women in North America have osteoporosis. There's a 20% prevalence of vertebral fractures over 50 years and older. So, and the reduced quality of life is similar to that with arthritis, COPD, diabetes, and cardiovascular disease. And we all know that those reduce quality of life. People just don't seem to have the same feel for osteoporosis. So we're talking about raising awareness here. And the fractures of the hip and spine result in increased morbidity, mortality, institutionalization, and length of hospitalization. And osteoporosis is underdiagnosed for a lot of the reasons I've already alluded to. It's a silent disease. There's a gradual onset of the condition. So again, a great opportunity for us to do assessment. We need to understand the definition of fragility fracture. That's a fracture that occurs in somebody where it wouldn't occur in a person that had normal bone strength. So, for instance, falling from a standing height or less, or even a vertebral fracture from just a coughing spell. And here's an important point, that studies show that follow-up diagnostic tests after somebody's been to the hospital for a broken bone occur in only 50% of cases or less, actually less than 50% of cases. So it looks like Mark has finished the test. I don't know if you noticed, but he kick-started that thing 3 times. There were 3 cycles that he went through. And as I mentioned, what this is doing is measuring the speed of sound through the bone. What we have is 2 different probes here. Mark used this larger probe, and there is also a smaller probe. The larger probe is used to measure the speed of sound through the distal radius bone. The smaller probe would be used to measure the bone in the third finger or the phalanx. Now, we use this 99% of the time probably The only time we would use this